Thank you, Rahul and Jim. Thank you for the invite. My job is to talk about discoid meniscus. Pediatric knee surgery is a big part of my practice, so we do see quite a lot of these. So are we all familiar with discoid meniscus? It's a variation of a normal meniscus. And just for people going for exam, the classic definition is if you see the bow tie sort of meniscus in 3 consecutive 5 millimeter MR sagittal slices, that's considered as a discoid. And in terms of a width of tibial plateau, if your meniscus is more than 20% of width or more than 15 millimeters, it's classed as a kind of a discoid. And in the axial one, it should cover more than 80%. So that's for the lateral plateau. So that's more for the exam in case you get asked. Okay, so but discoid is not just a morphological variant. It has lots of problems inside. Its vascularity is not good. The central part of the meniscus has no blood supply over there, and compared to normal meniscus where the fibers are laid all in peripherally in circumferential manner, in a discoid the central part is very disorganized. So that with kind of its deficient meniscocapsular attachment and the shape puts it at a higher risk of re-tear. So this is typically what you'll see when you go into a discoid meniscus. This one is unstable at the back. As you pull it, it will flop forward. So there is a common misconception that these tears are kind of resorption of the central meniscus, as in the fetal development of the fetal anatomy. But it's very rare to see a discoid meniscus in a fetal anatomical specimens. These menisci, if you look at histological studies, their matrix organization is different. They have a different cell type. It suggests there is kind of a deviation from the normal development pathways. So a different entity rather than just a kind of change in the development of meniscus. We don't know true prevalence because we see lots of asymptomatic discoid meniscus in older population, but they're more common in Asian population than Caucasian, and they're often bilateral, which is important, especially if you treated one side and you need to think about the other side, even though it may be asymptomatic on the other side. You would all be familiar with this Watanabe classification, where you've got a complete discoid, which is stable, and then there's an incomplete version. And then the third one, which is known as Risberg, and which has got a deficient posterior meniscocapsular attachment. And that's an unstable sort of variant. And often in MRI, you feel there's no attachment posteriorly, and they get a very hypertrophic ligament of Risberg, which is pretty much taking a lot of load and stopping meniscus from collapsing forward. There's a newer classification which Pediatric Research Society in Sports Medicine has given, which kind of almost like a tumor classification, includes width of the meniscus, the height, and it looks at the stability and whether it's stable anteriorly and posteriorly on probing, and also looks at the tear really. So if you notice a tear in the center part of the meniscus, it doesn't class as a tear because when you saucerize these, you are going to take that out. So it ignores them in part of the classification. Horizontal tears are common, and then of course, depending on whether there's tear at the front or the back, you get class, and that causes the displacement of meniscus, which leads on to the MRI classification. So if you got a tear at the back, these meniscus tissue, there's a plastic deformation, it just flows. So wherever there's a space, it just flows, and you end up getting a big meniscus shift, which is anterocentral, or if tear in the front, it will end up being posterocentral, or it may shift kind of centrally. Okay. So that's not an added sound, if you can. Okay. So this is a classic kind of snapping knee you see in these kids where they have unstable discoid meniscus, and often these patients may come with popping, sound catching, and when the meniscus flows and lodges in the front, they may have a loss of extension, and they come with a fixed flexion deformity. Okay. So once you've seen them, you do get X-rays, but they don't usually help really. If just for exams, the X-rays may show flattening of tibial spine, flattening of the femoral condyle, widened gap over there, and the fibula is more proximal compared to the tibial plateau. But it's essentially what you're looking for is an MRI. That's what you want. It gives you an idea of what sort of tear is it, is any substance changes, and where it has moved to, so that you can plan your treatment. But still, it can be difficult to confirm an incomplete discoid meniscus because they don't have a big tear, big tissue. But generally, they have a wide increased height at the periphery, and often, as I said earlier, they may have a prominent ligament wrist bug if they're hypermobile. So decision making, if they're asymptomatic, of course, you often see them in older people. You've done a MRFI, something else, you see a discoid meniscus. Of course, you're not going to treat them. I feel those are almost like a self-selected group. If you haven't torn your discoid meniscus till you kind of reach your kind of 20s and all, you're not going to tear them. So I won't treat them. But there's difference from this group. I mean, this patient recently had an ACL injury, and I saw kind of discoid meniscus, but because I was doing ACL reconstruction, I did saucerize this meniscus. But younger patients are different, really, and your threshold for surgery is different. If somebody has an MRI scan, a young person for a knee, there must be something going on. And if I see a discoid meniscus, I worry if that tears and that displaces, the consequences are too great. So my threshold for surgery is very low. Pretty much I might just advocate surgery for a younger pediatric population.